speaker, Dr. Santosh Kumar.
Good afternoon, one and all present here. I'm Dr. Shanmathi. I'm here to take you through a rare case of blister beetle-induced keratoconjunctivitis. Keratoconjunctivitis, as such, is an inflammatory condition which will involve conjunctiva, superficial cornea, secondary to viral, bacterial, autoimmune, and other allergic etiologies. Contact with blister beetle, as such, would result in the form of dermatitis, which would manifest as urticaria followed by blister formation due to the toxins released by blister beetle. Keratoconjunctivitis secondary to blister beetle is out of the common disease entity. This case report is presented owing to its uniqueness of being first time reported in India. Here, a 23-year-old patient reported to the OPD with complaints of pain, redness, watering, photophobia, irritation, along with blurring of vision in both the eyes for 2 days. Prior to ocular complaint, she had a history of fall of blister beetle over her right eye, and there occurred a onset of multiple painful blisters over the right eye. On further probing, she gave the history of accidental rubbing of the eyes with the fingers contaminated with the blister fluid. This is the hyperpigmented vesiculobullous lesion seen in the supromedial aspect of the right eye, and the best corrected visual acuity in the right eye was 6 parts, and there was lid edema with circumcorneal congestion, and there was an epithelial defect noted which was extending from 5 to 7 o'clock position in the right eye. And in the left eye, the best corrected visual acuity was 6-9 parts, and there was lid edema with circumcorneal congestion, and there was an epithelial defect which was extending from 5 to 6 o'clock position. Other anterior and the posterior segment examination were normal. As there were epithelial defect in both the eyes, patching of both the eyes was done after antibiotic eye ointment application. And on day 2, the epithelial defect in the left eye healed, whereas on the right eye, the epithelial defect reduced in size with reduction in the congestion. So patching was continued for the right eye after antibiotic eye ointment application, whereas for the left eye, topical antibiotic eye drops eye ointment along with the lubricants was continued without patching. On day 3, the epithelial defect in both the eyes got healed. On day 4, to reduce the ongoing inflammation, topical low-dose steroids was started for the patient, and in a course of 2 weeks, there was a reduction in the inflammation. Blister beetle, which is known as Rovi beetle, is commonly seen in Tanzania, Southern Europe, East Africa, and in some parts of Kerala, more prevalent in the rainy season. Among them, the Nairobi fly is most commonly involved in causing dermatitis due to the toxin released by them, the pedrin. The pedrin toxin will be released by the Nairobi fly only when it's been accidentally touched or crushed. Ocular manifestation usually occurs following the cross-contamination of the eyes with the fingers contaminated with blister fluid, manifesting most commonly in the form of periocular dermatitis, keratoconjunctivitis, filamentary keratitis, epithelial defect, and rarely corneal ulcer. Blister beetle-induced keratoconjunctivitis has a good ocular outcome if timely management and appropriate intervention is done at its earliest. Ocular presentation may mimic with herpes simplex, herpes zoster ophthalmicus, and other allergic contact dermatitis. The characteristic linear lesion not involving the dermatomes, an idea about the epidemiological factor helps in diagnosing the condition. Hope this case would guide us in keeping this etiology in mind while examining a patient with keratoconjunctivitis, especially from an endemic area. Here, these are my references. Thank you.
Thanks, Dr. Shanmathi. This is a very interesting case. I would probably ask that you've done a nice documentation, but there are certain conventions of corneal diagrams, including cross-sections and so on. There are certain color codings. So maybe in future, if you incorporate that, because those conventions are there for a reason. When you present that, any other ophthalmologist will be able to identify exactly what you're depicting. That's why the conventions are in use. Thanks.
Was there any lag ophthalmos?
No, sir.
Why I'm asking is both the epithelial defect are inferior.
Yes, sir.
So maybe whether the lack of ophthalmos has any contribution to that. That's what I'm asking. Was there a chemosis?
Only lid edema with circumferential epithelial defects.
Okay. Okay.
So